trying to find a parking place. I think when the red bicycle opens tomorrow, it's going to get worse. Especially if you like crepes. Okay, Ms. Thompson, if you would please call the roll.
Preble Acton, Rhonda Allen, Dr. Andrea Anthony, Doug Bodery, Amber Brown, Shay Crowell, Holly Deering, Brian Gaither, Mary Hickerson, Lois Miller, Alan McAdoo, Jeff Phillips,
Here.
Shantae Sherrill, Eric Tutobeni. We have a quorum.
We have a quorum. We're now ready to conduct our business today. Yes, ma'am. Yeah, she walked in. Sure did. Okay, next on the agenda is approval of the minutes from the last meeting. Has anybody read them? Okay, thank you. Glad somebody said that. Because I was getting ready to say, does anybody care? No, but yeah, Mary was on the motion. Is there a second? Got a second. Without further discussion, all those in favor signify by saying aye. All opposed, motion carries. Next, Mr. Elam, I'll call on you for financials.
All right, we have for the calendar year, for the month of September, since we didn't meet last month, you have $9,066,351 in revenue, expenditures $6,781,043, for a difference of $2,286,308 on the positive side. For the calendar year total, you have $62,033,757. For expenditures, you have $65,884,536. Revenue less expenditures is a negative $3,850,799. Total enrollments is 6,302. And then for the fiscal year, your revenue is $12,770,279. Expenditures $22,138,060. For a revenue less expenditures, a negative $9,367,781. The 264 fund for the month of October. Revenue, $7,637,269. Expenditures, $6,502,835. Revenue less expenditures, it was a positive $1,134,434. For the calendar year totals, revenue $69,671,026. Expenditures $72,387,392. Revenue less expenditures $2,716,365 on the negative side. Enrollment 6,288. And then for the fiscal year, the total revenue is $20,407,548. Expenditures $28,640,895. And your revenue less expenditures a negative $8,233,347. 266 fund. On the 266 fund for the month of September, workers' comp, $2,139.16. OJI, $23,871.92. And we have a total of $26,011.08. Year-to-date is for workers' comp, $9,668.19. OJI, $161,235.03, for a total of $170,903.22. The 266 fund for the month of October, workers' comp, $1,988.76. OJI, $26,631.97. For the month of October, total is $28,620.73. For the year-to-date is workers' comp, $11,656.95. OJI, $187,867, for a total of $199,523.95. That completes my report, Mr. Chairman.
You've heard the report from the director. Are there any questions? Seeing none, is there a motion for acceptance? Got a motion from Lois Miller. Is there a second? Second. On second. Mary? Had a second from Mary Hickerson. Further discussion? Call the roll, Ms. Thompson.
Rhonda Allen. Yes. Dr. Andrea Anthony. Yes. Doug Bodery. Yes. Amber Brown. Yes. Shay Crowell. Yes. Holly Deering. Yes. Brian Gaither. Yes. Mary Hickerson. Yes. Lois Miller. Yes. Jeff Phillips.
Yes.
Shantae Sherrill. Yes. Eric Tutobeni. Yes.
Motion passes. Item number 3. Mr. Good, Dan Good, please come forward for our work comp OJI report. Yes, sir. Recognize.
I'll be reporting for the month of September and for October. In the month of September, we had a total of 19 injuries requiring medical attention, bringing the year total up to 130. 91 of those were OSHA recordable, with 47 being restrictive days, 19 lost time days, and 25 all others. On the next page of the report, you'll see that brings the graph compares the 130 this year to 119 last year and the 207 in 2019. The incurred dollars for the month was $27,500, bringing the year total for 2021 to $467,000 compared to $594 for last year and $375 for the previous year. On the last page of this report, you'll notice that 14 of the injuries were within the Board of Education, 5 were in the County General, and we broke down the 5 in the County General to the Sheriff's Department, PAWS, and OIT. In the month of October, we had a total of 15 injuries requiring medical attention, bringing the year total to 145. The total recordable at this point is 106, 56 restricted days, 25 lost time days, and 29 all others. Comparing this year 145 to the previous year of 137, and to 2019 at 228, excuse me. The total incurred dollars for the month were $17,000, which brings the year total of $484,000 compared to $714 last year and $415 the previous year. The breakdown for the 19 injuries for the 15 injuries were 9 in the Board of Education, 6 for the county general, and they were broken down across the county for the sheriff department, PAWS, and the EMS. Do you have any questions, or?
Any questions for Mr. Good?
That completes my report, sir.
Thank you, Mr. Good. Is there a motion for adoption of the report? Brown on the motion. Is there a second? Second by Ms. Deering. Any further discussion? Seeing none, all those in favor signify by saying aye. All opposed, motion carries. Thank you, Dan. Next, we have the wellness update. Smith, please.
Lee's not here. I'll handle it for
All
him.
right, go ahead.
Okay, for the Smart Steps month of October, instead of reading each line item, I'll just go over the Motivate Me, Meet Each Goal. If you look at each line item, just about every single one, you'll see an increase over 2020. But the Motivate Me goal met all 4,054 2021 compared to 3,079 in 2020. And that's the month of October. Month of November, goal met would be 5,131 in 2021 compared to 2020 at 3,164. And if you remember, in comparing the 2021 to 2022, it was not a requirement to meet the county commission decided not to make that requirement due to the COVID restrictions in 2020. So that requirement was lifted. And it's a good indication, the difference in the points, what it's doing as far as getting people to go see their doctor, get their exams and things like that.
That concludes the report.
That concludes my report, Mr. Chairman.
Okay. Any other questions on the wellness update? None, we'll move into our Midpoint Report. Ms. O'Neill? How are you today? Welcome. Doing well. Thank you.
So I'll go through the September report first, and then I'll do the October report. For our visits in the month of September, we saw 1,371 visits. Of that, 1,177 were unique members. Our New Salem location saw 812 visits, our Stewart's Creek location 318, and our Walter Hill location 241. I know that you guys have asked a little bit of comparison between months and years and visits and whatnot, so I did take a peek since we had September to September now of the 2 years. In September of 2020, we did see 563 visits versus September of 2021, we saw 1,371 visits. So that was an increase of 808 visits. In full transparency, though, we did some biometric screening events in September of 2021 that we did not do in September of 2020. And I'll go into some of those totals for the biometric screening events in just a little bit. In our visit summary by member type, we saw 91 children, 1,036 employees, and 244 spouses. 156 members had more than one visit in the month of September. One member had 7 visits, one member had 6, and one member had 5. 3 members had 4 visits, and 150 members had 2 to 3 visits in the month of September. All of the high number visits, the 5, 6, and 7, were all COVID positive patients, and most of them were post-hospitalization. And of the others, they were often a combination of wellness exams, biometric screenings, and care for issues found at those annual exams. With that, 272 members and dependents had their biometric screenings at those biometric screening events in September. So we had 3 of them on 3 Saturdays in the month of September where people could come in and get their biometric screening only to get their points. And so 272 people took advantage of that. On page 6 on our visit summary by day, September had 25 available scheduling days, and there were 5 Wednesdays and Thursdays in the month of September. The health centers were closed on Monday the 6th for Labor Day, but Monday was still the busiest day of the month for September. On page 7 in our in-person versus virtual appointments, we had 154 virtual appointments in the month of September. Walter Hill continues to be, on average, the one with the highest virtual utilization, and that was true in the month of September as well. New Salem had 8.62% of their visits virtually for 70 virtual appointments. Stewart's Creek had 9.75% of their visits virtually with 31 appointments. And Walter Hill had just under 22% of their visits virtually with 53 of them being virtual. Almost 60% of those seen in the month of September virtually were actively ill. And just over 40% had their regular routine care done virtually. Of course, we can't do annual exams and whatnot virtually, but we can do things like medication refills, checking in on ongoing issues like blood pressure management and things like that virtually. And continuing on with our virtual appointments, we have had a total of 10,377 visits between September of 2020 and September of 2021. Of those, 8,344 visits have been in person. 2,033 of them have been virtual, which is like 19.5% or so virtually being seen in the clinics. And in the month of September, it worked out to being just over 13% being seen virtually. On page 9 for our referral summary, we did a total of 94 referrals within the clinics. 38 were given at New Salem, 40 at Stewart's Creek, and 16 at Walter Hill. Gastroenterology was our top referral source with 21 referrals going to them. Our in-house dietitian was second with 16 referrals to her, then followed up by behavioral health, sleep medicine, physical therapy, hematology, oncology, cardiology, orthopedic and orthopedic surgery, dermatology, and rheumatology. On page 11 for our financials, in the month of September, there were 1,177 total unique members. We had a total operating cost of $189,682.42. The total employee count was 6,341 for a PEPM of $30. On our population health analytics on page 13, our general adult medical exam and screening for diabetes were the top diagnosis for the month of September, with 31.15% of our top diagnosis codes going to that encounter for general medical exam and 25.37% for that encounter for screening for diabetes. And of course, that screening for diabetes is part of that biometric screening, so which is why that's so high up there on the list most likely. Then that was followed by screening for lipid disorders. And then further down the line at just over 3% was essential hypertension, just over 2% anxiety disorder, just under 2% diabetes with or without complications, then pharyngitis, encounter for screening cardiovascular disorders. COVID-19 is on the list now this month in our top 10 diagnoses, and that's for not screening for COVID, but that's actual positive COVID, and encounter for immunization. On page 14, for our visit demographic summary, in September, 57.53% of the members seen were female, so we had almost a half and half, which is nice to see. And the age range of 40 to 49 in both female and the male population were the highest population seen. But that being said, there is actually a very good representation for ages between 10 and 69 throughout, and even 19 members that were in that 70 to 79 bracket and 4 members who were in the 80 to 89 bracket. So we had a good, kind of span of all age groups coming into the clinics in September. And on page 15, you'll see our BMI summary. In September, the female and male member highest percent of BMI was in the overweight category of 25 to 29.9. And that concludes my September report. I'll move on to the October report. So in our October visit summary on page 3, you'll see that the health centers saw 1,036 visits in October, and of that, 878 were unique members. New Salem saw 627, Stewart's Creek 208, and Walter Hill 201. In our visit summary by member type, we saw 165 children, 736 employees, and 135 spouses. On page 5 for our visit type summary, we had 54 annual visits, 19 dietitian visits, 429 established patient visits, 304 flu shot event visits, 22 new patients, 90 nurse visits, 29 telehealth phone visits, and 89 virtual visits, which include the video component. 116 members had more than one visit in the month of October. 1 member had 7 visits, 6 members had 4 visits, and 109 had 2 to 3 visits. Again, COVID positive patients represented nearly all the patients with 4 or more visits. Sick visits combined with wellness care or COVID positive patient care represented most of the others that had multiple visits. October had 26 available scheduling days. There were 5 Fridays and Saturdays in the month of October, and Thursday was the busiest day in the month of October. And on page 7, you'll see that we had a drive-through event. And again, in full clarity, we did not do all of these in the month of October. So that's why the numbers you'll see are a little bit different than the totals you'll see on the October totals. But we did 4 events, 2 of them in October and 2 of them in November. And with those, we did 410 flu shot injections at our drive-through flu events. We did 116 at the Agricultural Center on October 21st, 188 at the New Salem location, another 69 on the Stewart's Creek campus, and then we had a final one on November 13th to catch those, stragglers at New Salem, and we did another 37. So that was an increase of 119 over last year's flu shot drive-through events. In our inpatient versus virtual appointments, we saw 118 virtual appointments in the month of October. Again, Walter Hill with the highest average utilization. New Salem saw 6.54% of their patients virtually with 41 visits. Stewart's Creek saw just over 15% of their patients virtually with 32 visits. And Walter Hill saw just over 22% of their patients virtually with 45 visits. Of those, about 35%, just under, were seen because they were sick, and just over 65% were seen for just their regular routine care. So it was nice to see that kind of switch back after September. Again, we are not requiring sick patients to be seen virtually. That is at their choice. And continuing on with our virtual appointments, the total visits from September 2020 to October 2021 was 11,401 visits. In person was 9,255, and virtual was 2,145 for a total for that full span of about 18.8% being seen virtually. In our referral summary, we did 86 referrals in the month of October. 35 at New Salem, 24 at Stewart's Creek, and 27 at Walter Hill. Our dietitian was the highest source of referral in October with 18 referrals. Then gastroenterology, sleep medicine, dermatology, urology, physical therapy, hematology, oncology, pulmonary disease, orthopedic and orthopedic surgery, gynecology, and endocrinology. In our financials for October, we had 878 total unique members. We had a total operating cost of $161,321.95, a total employee count of 6,308 for a PEPM of $26. And in our population health analytics, the general adult medical exam and encounter for immunization was the top diagnoses for the month of October. The encounter for general medical exam was just over 17%, and the encounter for immunization was just shy of 6%, and of course that's likely due to those flu shot events that we had been doing. Then followed by that was anxiety disorder, essential hypertension, sinusitis, pharyngitis, because, you know, we are kind of in that flu sick season that we're in, so we're seeing more of those symptoms. Then encounter for screening for diabetes with or without complication, encounter for screening for lipoid disorders, encounter for gynecology exam, and mixed hyperlipidemia. In our visit demographic summary, in October, 67.45% of the members seen were female. The age range of 40 to 49 in the female population and the age range of 50 to 59 in the male population were the highest population seen. But again, we did see a good balance of patients of all age groups coming through between the ages of like 10 and 79. I mean, we saw 94 children. We saw 24 people who were in that 70 to 79 bracket. So it's not a vast difference with those age groups. And in our BMI summary, in October, the female and male member highest percent of BMI was in the overweight category of 25 to 29.9%. And that concludes my October report and my report in general.
Any questions, Lois?
One, we noticed after a month that the referral. Have any idea what the percentage of continuing?
I didn't have that prepared for today, and I would hate to give you wrong numbers, but I'd be happy to kind of look into that for next month and could bring back some information on that. I like seeing that, you know, I don't like seeing that the highest percent of BMI on those for both months was overweight, but, you know, previously they actually had been in the obese category for a long time, so I'm definitely seeing some improvement with the metrics there. I'm hoping that's because we are referring to the dietitian so much. Mm-hmm.
Other questions, Ms. O'Neill? I have one.
Yes, sir.
It appears, Ms. O'Neill, every month we seem to see, looking at our census data, that Walter Hill has the highest average of virtual utilization. Are you all tracking that data as far as, I mean, I'd like to know. I think our virtual utilization would be cheaper, right, than actual in-visit utilization. Do we have more broadband or fiber in that area? Are there age group younger who like using virtual versus a 30-year-old person, 50-year-old?
So
That's
I
interesting
don't
data
have.
I'd like to look at.
I don't have the specific, like, I haven't run any real data on that to give a broad answer, but I can give you kind of some anecdotal answer from what I've gotten from feedback from patients.
Okay.
So my understanding of it is it's a couple of things. One, it's the location of Walter Hill. The space constraints and whatnot, it makes it harder to kind of put patients back to back, so we'll offer them virtual and they can get more of the timing that they want to be seen, so that they can fit in, whereas maybe we'd have to push them out a little bit further if we had to see them in person because the room wouldn't be available and whatnot, whereas we could have two patients technically in clinic at the time because one's virtual and one is physical.
That makes sense.
The other thing that we see a lot of is we see a lot of the Walter Hill staff, and they like that they don't have to leave their classroom and they can be seen, so that they can just quickly get it taken care of from their classroom versus having to leave the classroom, come to our clinic, find someone to kind of cover their space, and then come back. So we see a lot of them literally just down the hall from their classroom. And so, we've gotten some anecdotal feedback on that they like that. I know today alone, while I was at Walter Hill this morning, we had a teacher who was in her classroom that we saw who was literally rooms away, but it was just way more convenient for her.
So she didn't have to get in the car and go somewhere.
Well, and not even just get in the car because we're in the same building, right? But she didn't have to
comfortable.
leave her room.
Right.
If somebody needed her, if somebody needed to find her, they know exactly where she is, and she doesn't have to leave that space to come to us for something that she doesn't need a physical exam for.
Right. Makes sense. Okay, anything else? Any other questions? All right, certainly appreciate your report today. Thank you. Next we have Mercer. We're going to talk about our pharmacy, item number 6, pharmacy 2022, and an RFP. going to be suggested. Gentlemen?
All right, thank
You're
you.
up.
Thank you, sir. First, I would say I want to thank the Risk and Insurance Department. Open enrollment is almost finalized for the year, so I know
Yay.
their team has been very busy talking with over 6,500 employees. I don't know how many members, retirees in tomorrow, right? Is the open enrollment for retirees tomorrow? So
And I'll give them kudos too. I mean, it's a small department to handle that many bodies. It's quite a feat. How many, what's your total staff? 8?
Dan's one of those.
Okay,
Doesn't deal with benefits.
okay, so 7. Sorry, Dan. Unless you want to step it up, Dan. Hello? Dan? Hello, Dan? Are you there? Okay. Okay, we have 7. All right, well, thank you.
yeah, well, thank you. And I say that because I know there's a lot of work put into that this year. And as we start the pharmacy RFP, what I would say, where I was going with that is obviously earlier this year, it seems like 2 years ago, but earlier this year, we released the RFP for the medical, the dental, the vision, the stop loss, the pharmacy, went through that analysis with the committee. The decision was to stay with Cigna, if we recall. And so that was part of it. We did make some changes to the plans, which I'll discuss in a second. But one of the things that we kind of put on the back burner was the pharmacy discussion. And if you guys remember when we talked about that, we said pharmacy is its own unique plan. So we wanted to work with Cigna to get everything decided for, I believe we ended up with a 3-year contract there. And then as we continue to work with Cigna on a quarterly basis, we do see the pharmacy, especially the specialty drugs, continue to increase. And so one thing that we are working with the insurance committee and with Cigna is to go through the pharmacy plan, look at options to control that cost. And we are going to ask, I guess, to do a pharmacy RFP. Have our pharmacy team review that, send it out to the market, just to make sure we're doing our due diligence to make sure the 25-28% of the overall medical spend is in that pharmacy space, that we are looking at everything that's available in the marketplace, and being a good steward of that money. So what we are asking today is one of the topics is looking at that pharmacy. So the goal would be a notice would go out over the next week or so. RFPs would be released. We would give the PBMs about a month or so to review that. And the goal would be to come back in January and present our findings, and then if needed, a finalist meeting in February. But that would just be specific to the pharmacy.
You feel it with the holidays upon us that there's enough time?
It's going to be tight, but we've already been preparing. We've been doing a lot of work behind the scenes to get the RFP ready to request the data from Cigna and try to get that out there. But I feel like as long as we can stick to the plan, that's our goal, is to have findings back to you by the January session.
Okay, discussion, Mary?
Okay, when we did this, the pharmacy was put in with the medical and all of that, and all of that currently falls under Cigna, and we generally do a 3 or 5 year contract, or maybe 3 with 2 extensions or something. Where are they at? I mean, we're locked in for, aren't we? We just did this, so we're at least locked in for 3-ish.
Right.
So how would this affect our current contract with Cigna if they didn't get
Right.
pharmacy
Good question.
to retain it?
Good question. I probably should have even addressed that. But essentially what we're in the process of doing, that's why we're bringing our pharmacy team, kind of like we brought in the on-site clinic team when we went through that analysis. This is a pretty large undertaking, and part of that analysis will be looking at the PBMs in the marketplace to see, what would be the best fit for Rutherford County and the schools. And then the other part of that process will be if the decision isn't to remain with Cigna and potentially move with another PBM, then the conversation will be with the Cigna team is what would the changes potentially be for carving out the pharmacy? Would our fees go up? Would there be any claims adjustments needed? And our pharmacy team does this all the time. So essentially we've already worked with Paul and the team to say, we can do this RFP. If the decision is moved, then essentially those fees that were discussed will have to change. And so we'll be asking the Cigna team at that point, what is the new ASO fee? What is the potential change to the claims? And then our team will kind of do the analysis to say, if there's savings in the pharmacy, but the fees go up on the medical, or the medical management is different because we don't have the consolidation of the two together, working together, we'll be able to do that analysis to say the PBM savings are X, the increased cost to the medical is Y, and then does that still make sense to carve that out or not? And we've gotten the commitment from Cigna that we can essentially break that contract, but the fees will change if we decide to pull out.
Okay, a couple of things. If we do change on the pharmacy part from Cigna, is there a penalty? And then the next thing is, do we foresee that we would get potentially better numbers by pulling pharmacy out instead of doing, not even thinking medical, but it looks to me like you could get a company to get you an RFP based on medical and pharmacy together, instead of now we're just looking at pharmacy. Do you really think the numbers could potentially be that big of a difference that you're going to get companies to come and say, oh yeah, here's our pharmacy only, when we didn't get much back when we were doing a big group of medical with the pharmacy included?
Right. It's a good question. Essentially, when we looked at, and there were 5 things we looked at last time. And so the goal is, to your point, the dental, the vision, the medical can be tied together, and there's some package savings there. The stop loss a lot of times could be separate. That could be different. And the pharmacy is just unique in itself. And so when we did the analysis to select Cigna, and we met with you on that as it related to the medical, a big part of that decision is really, are you with the provider that has the best network in the market, and do they have the best discounts? 85% of the overall medical spend are your claims, not your fixed cost. And so when we did that analysis, we wanted to make sure, did Cigna have the best discounts in the Middle Tennessee area? And that was true. The fixed cost of the total, we'll call it $80 million spend, are a small percentage. And so that's really the piece we'll have to wait and see. I don't know, I don't have the answer to answer the question, but I would say we know for sure, based on that analysis, that we all kind of sat in on, that Cigna's the right vendor for now for the medical. If you recall, we really didn't do a deep dive in the pharmacy because it requires its own RFP. I mean, you'll see when we do this analysis, that's why we have our specialists coming in to do this. You'll see that we'll be looking at script fees and formularies and creative ways to try to manage your specialty. We thought when we looked at that bigger one last year, that was just too much to get into at one time. But as we do see the costs continue to go up, we think it's probably the time to do that. And we'll see. I don't know. That's the question we continue to have too. Will the savings outweigh the potential cost to carve it out? And so we will show that to you on a standalone basis, as well as the cost to package it together, in that January session. But we've kind of committed to the county, to the school board, to do our due diligence to make sure, is that a rock we didn't fully uncover last time, to make sure if there's any savings there.
And just because we put it out in RFP doesn't necessarily say that we're changing.
Right, that's right.
We're just looking at the market.
We really didn't have any PBMs respond to it. Only the carriers that offered the medical and the pharmacy together, I believe, are the only ones responded. There are some standalone pharmacies that didn't participate because they kind of probably saw the RFP was somewhat lumped together, and it wasn't probably a good use of their time to do that RFP. So we'll get some competitors that might propose a quote that just didn't do it last time.
Okay, so when Cigna comes in, and what Mr. Mayor just said, we wouldn't necessarily have to take theirs, so we really wouldn't be cutting our nose off to spite our face. If we done this, we can still stay where we're at. We don't have to I know we don't really have to make a change, but could it affect Cigna's numbers with us that we're on a contract with?
I don't believe so. If we decide to stay with Cigna, the current medical, dental, vision, stop loss, those things would stay the same. The only change would be as if we decide to pull out. Yep, that's a good point.
Lois?
Okay, with having both the value to be added by the coordination of benefits. Fraction to that. Are there other PBMs out there that can?
I mean, what's coordinate with the medical as far as with Cigna? I mean, when we looked at it, I mean, to be fully transparent, a lot of our larger clients are with a third-party pharmacy PBM. And so that was part of this analysis. I mean, you guys have over 6,000 employees. I mean, over, 13,000 members. And so when you get to a certain size, it's definitely worth doing that analysis to see what may be out there from a standalone PBM. But you're right, there is some coordination with the medical that we would say, and I think you would agree, and I know Cigna agrees, that you lose. But then on the flip side, we know a lot of our clients have it carved out and enjoy that.
I guess my question is, would another PBM be able to do the same type of coordination? Would they receive data that they needed to coordinate in that manner?
You mean as far as just the deductible and the out-of-pocket coordination, those things are actually managing the claim?
Actually helping to manage the claims to drive, because you're talking about driving down the specialty, and wouldn't they require that? I'm just asking because
Right.
it speaks.
Right.
Another PBM
Could do that.
get that data and perform the same.
I'm not sure. I mean, that'll be something we'll definitely ask our experts on our team to look through that, but I think it's good.
Other questions for Jay? So what we're looking for is a motion to move forward on allowing them, Mercer, to put together an RFP and put it out and report back to us sometime in January, 1st of February. Have a motion to approve. Second, Lois. Any further discussion? All those in favor signify by saying aye. All opposed, motion carries. Thank you. Item number 7, deductible plan, grandfathered. Mercer, Jay, you're up.
And along those same lines, there are some things, like we said, we had a lot of change last year. You know, we glad we renewed with Cigna for all those products. That could have been another change, but we were able to keep the carriers the same. But we did, change from the HRA to the HSA. We added the Cigna Local Plus Skinny Network. And I will say, we have gotten the new enrollment for the most part in. Our actuaries working with the risk management team were pretty much in line what we expected to happen there as far as the enrollment in the Local Plus. Depending on the two plans, overall, we were able to get around 25% of the group in the smaller network, and that was right on with what we thought. We currently have, I believe, about half of the group in the PPO plans and about half of the group in the HSA plan. So not a lot of shift when we moved from the HRA to the HSA. So, even though we ended up, I think, at like a 3.5% overall increase to the health plan, making some of these assumptions, we never really know until we get the data back. So it came in right in line with that. So the good news there. The one piece that we held off on was the deductible plan. It's been in conversation the last couple of years, and the deductible plan continues to lose enrollment largely due to it runs hotter. The claims to premium are always worse in that plan, so we typically pass a little bit more of the cost on to the member there, where it's got to the point where I believe the last count that we saw, we have 158 employees still in the deductible plan. And so we're definitely to that point where the recommendation is to, I guess, remove the deductible plan effective next year, so 2023. And we want to talk about that. It may be that we, offer a second PPO plan. We may make the one we have a little richer. There's still some things we want to talk about as we start strategy the first of the year. But one of those things we wanted to talk about is removing the deductible plan, keeping the current copay plan and the HSA, and then that leaves room for potentially a conversation around another plan or something else we could do there. But with 158 employees out of over 6,000, it's obvious this plan is not attractive to most of the population. So we want to ask to remove that for next year.
Questions on removing the deductible plan? Mary?
Well, I have some of my employees still on the deductible plan, but you don't really want to say a deal was made, but it was. When the 21 commissioners decided that we're going to get it down to, we were the shared portion and get it down to 80-20 on how much the county will pay and how much the employee will pay on the premium. And then we did look at the deductible plan. Well, at that same time, the commissioners did draw a line in the sand of 300, 200, and if it got below that, then it really wasn't feasible for the employees or even for our county, the insurance plan. So I was a proponent for doing away with it last year because we had definitely got below, well, I should say for 22, because we did get below the thing. So, I mean, we can discuss it, but, the 21 commissioners have been very fortunate and lucky for us that we have kept it. So I think now we're definitely way below because I do see what my employees are paying, and it really is, considering I know some of their health situations, it would not be that big of a burden to do the copay once they understood it, and some of them were just hanging on until we forced them off for a better term. So we can keep discussing, but I'll go ahead and make the motion to go ahead and do away for effective 1/1/23 to do away with the great deductible plan on the medical.
Have a motion. Is there a second? Have a second. Chairman Allen, any further discussion? Let's call the roll on this one. Susan, call the roll, please.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Doug Bodery. Amber Brown. Shay Crowell. Holly Deering. Brian Gaither. Mary Hickerson. Lois Miller. Jeff Phillips.
Yes.
Shantae Sherrill. Eric Tutobeni. Seven yes, 5 no.
Motion carries. All right, next is the state plan discussion from Mercer. Jay?
All right, as we look at the state plan, if you recall, like we said, we made some changes last year. We looked at benchmarks. Typically with Mercer, as we start strategy, it seems odd that we're already starting strategy for 23, and we're not even finished with open enrollment, but that's typically what we do as we get our years mixed up a little bit. But as we're thinking towards 2023, as I've said a couple of times, last year we made some changes to the plan. As we look at benchmarking data, we look at the state plan, we look at how we want to really design the county and the schools for Rutherford County. And so we made the change to the health savings account from the HRA, and we added the local plus. And those were two things that were offered by the state plan that I think have been welcome. We had very little removal from the HRA to the HSA. We had great participation in the local plus. It allowed us to get down to a 3.5% rate increase, which is great. The two things that we really tabled for the discussion this year was the pharmacy, which we've already discussed, and then also the retiree plan. And so we're having a presentation from Paul here in a second about the retiree plan. But as we look at the state plan and how it compares to what we offer today, the two things we really want to pursue as we talk about 23 is, are there ways to enhance the retiree plan and potentially save the county and the school board money? And once again, the conversation on the pharmacy that we're going to look through. And then is there an opportunity to use some of that money to potentially, keep our costs down, offer more options of different PPO options, make those plans potentially richer. So there's definitely some strategy that we want to use those potential savings. But that's what we wanted to see. I believe, Ed, maybe looking to have a full presentation next month of the state plan. I don't know if you want to speak to
Yes.
that, but as far as strategy goes, as it relates to Mercer here, we've been to some of the school board meetings as it related to the state plan, and knowing our strategy of a multi-year approach, that was the two things we wanted to look at this year. Once again, we're going to talk more about that here in a second. We'll talk more about it even, I think, next month. But as it relates to us and strategy for the larger group, as it relates for 23, those were the two things we want to look at over the next couple months, and how we can continue to keep the cost down, offer more choice to the members, and potentially richer benefits. But we are looking to have the state people here next week to do a presentation, more of a side-by-side comparison of plans and networks and different things like that. I don't know if you want to add anything to that, but that's what we want to look at for next month.
Ed?
Yes, the goal next month is to have a presentation. I think what we look at is three different things. We all stay together as a family, or we go our separate ways, or we all go together as the state plan. So that's kind of the three things that we would look at. The reason why it's on the agenda today is the most important thing is as committee members, just to give a little explanation, it's a very important decision that they will have to make. Part of that's with the schools, with their decision that they make. That is their decision to make if they want to go to the state plan. But what that does is what's the county plan do? And then what's left? And whether the county general goes to the state plan or whether we stay with our own plan. So you'll be getting a lot of information between now and the next meeting, and just carefully look over it. You have any questions, shoot us some questions, so hopefully we'll have the information that you're looking for in December. I intend to call the state and see if they will make a presentation on their part for the committee. They've made several presentations, I know, for the Board of Education, and then, in December, I don't think you're going to have, well, I'm not sure, but I don't think you'll have to make a decision what we're going to do unless the board plans on making their decision before December. Do you know whether or not they're going to the state plan, or do you anticipate a decision being made before then? Okay. So our idea is to be able to provide you with that information when the decision has to be made, is that it won't be like it's all dumped on you at one time, because it's very complex. There's a lot of information, a lot of data, a lot of questions, and it affects a lot of different groups of people. So when the decision is made, I want to be able to, again, we may even have a special session just to deal with that. But that's what the goal is at this point, is to set up December's meeting and try to make it a very strong presentation and give you the information that you need, maybe even to ask more questions.
I'll follow up for a moment for the purposes of discussion. I think this is a very important decision this committee will be making, so it's very important that if all possible, please be here for the December meeting. What we know is that we're going to have to make some decisions. Healthcare costs continue to rise. Okay, things are not what they were 3 years ago, or more so even 5 years ago. If the school board chooses to go to the state, then that drops our census for a county general, naturally, because the census is not as large. We're down to 1,600, right? 1,200? 1,200 versus over 6,000. So naturally, those numbers will make a big difference in the rates. So if you're looking at 1,200, when you go to a company, the rates are going to escalate for county general. Or we stay together. If the state goes, then we may be forced to go just because of cost. But what we want to make sure is not only do we have exact coverages, we also have networks, the doctors, etc. making those decisions because things, like I said, change, and we have to be flexible enough to make those changes for our employees. If we can save close to $3 million, and we'll hear that in a few minutes, going into next year, 22-23, right? Then I think we're forced to look at that, keeping the cost down, as long as we don't lose those coverages, and that's what we're getting ready to hear from Paul here in a moment. Mary?
One of my questions, and one thing that always concerns me when we do changes, is how is it going to affect the employees that have worked for the county for so long and have already retired, so they're on our retired insurance plan? Could we have a definite answer? I'm not looking for one today, but I think we need to look at what does going to the state plan, BOE, us, all of us, whatever, for our retirees, pre-65 and post-65. I have heard there is no post-65 retirement or retiree insurance on the state plan. So I definitely, I can put it in an email too, but I definitely want that answer when we start talking. That, to me,
Sure.
is a big thing when the state rolls in here.
The state does not have post-65. We eliminated that when I was still in the Senate in 2015. Anybody prior to that was grandfathered, but they don't pay for retirees at all. They just, you're on your Medicare, and you have to buy a supplement. Sure. Jay, are you through that discussion? Are we ready for Paul? Jay, I'm sorry.
Hey, I talked to some of the state people, and what they said is that if we had an employee that was employed before 2015, when the state made that change, they would be grandfathered in if they're post-65.
Yeah, that's what I said a minute ago. If you were an employee prior to 2015, you're grandfathered. I'm on that plan, I was grandfathered. Okay, but the coverage is not quite as good and more expensive. That's what I could get with the county. Paul? Oh, Sonia?
And one of the things would be anybody after July 1/15 would not be qualified for it. But the other question I would ask is, under our current situation, it's cumulative years of service to qualify to keep your retirement, post-retirement. So, for example, if somebody worked for us for, 5 or 6 years and they left and then they came back and worked for us 10 years, as long as they met the qualifying factors. My question would be to the state, with it being, is it the original hire date of pre-July 1/15, or do they consider their current hire date? So say somebody did work in 2 or 3 different stints with employers, and not necessarily the state, but with employers who had the state plan, and they left and came back. Are they looking at their current hire date full-time, or would it be their cumulative? Because if it's their current hire date and they came back in July 20th, even if they worked 25 years before and they're not qualified, then they're, with us, they would be qualified for their cumulative years of service.
Well, I would like to say that it would be cumulative, but knowing the state and Ms. Lori Lee, who directs that program, probably not. It's probably not going to be the same as our TCRS. That would be a cumulative, but on the health plan, probably not. Any other questions before Paul comes up? Okay. Chairman and Lisa.
I watched the presentation at the health board or the school board, I'm sorry. And I think one of the things that they can do when they come present to us that would make it a little bit clearer is if they will give us actual examples of families and their premiums and what that means for deductibles and copays and out-of-pocket maximums, really lay it out. Because when they presented it at the school board, they just put premiums up there with no other real context. And so I think if they actually can drill it down, just explain it as you would to a lay person, that's what we need to hear. I think that would be helpful. I also want to know, as we look at this decision, and some of Mary's comments earlier made me think about this, we're also in a contract with the clinics, with Ascension. And so are we going to need to keep clinics? Are we going to eliminate clinics? Where are we in our contractual relationship with the clinics? What's our out clause? What are expenses associated with that if we make a change with that? I want to know that impact. I also want to know the impact on our contract with Cigna, because there's going to need to be a run out period because we're going to have old claims that need to be adjudicated. So again, I want to know all the ripple effects of this decision. I also had on my list the retiree impact that Mary mentioned. And then I also want to know if there's anything specific that is a distinguishing difference between what the teachers would be going to and what county general would be going to, because I know we're hearing and talking a lot about what the teachers are going to go to, and I know there is a plan for county general, but I don't know that they're identical. I don't know if they're different. I don't want there to be any assumptions made that one's getting something and the other one's automatically getting it. They might be identical. I don't know that, but those are just some of the things that as we drill down into some specifics, those are some things that I'd really like to hear next month.
So, Mr. Elam, those are all good questions, and if you couldn't write them down fast enough as she was saying them, you may go back and look at the video and write them down and pose those questions and tell them to come prepared to answer those questions. Those are good questions that need to be answered. Even though they're a lay person, still that's who's affected, and they're the ones that need to know. Lisa?
And I'm following up on what you said, because the rates, from what I could tell, the rates for education is different from the local plans. What I would like to be able to see, which I have such a difficulty comparing what rates they have posted to ours and being able to say, does this plan equal this plan? What is level 1, 2, and 3? What's regions? I can't figure it out. And so if the state could tell us that this plan equals whatever, our two plans are, so that we could somehow get it to apples and to make it clear. And following up on what
it would probably be good, Mr. Elam, if you could put it on to where we can put it up on the screens as well when they come and make that presentation, so everybody could actually see it. And we'll work that out with IT.
And then
Tanya?
the eligibility.
Eligibility
between
classes.
ours
Correct.
and theirs.
Tanya?
So following up on two things, one that Commissioner Allen said was also, in just my brief research, I think that there's a difference in the premiums for when you're looking at a school system, even the difference in the breakdown of the premiums between the certified and their classified staff. So if I read it correctly, the teachers get one premium and the cafeteria workers and everybody else gets a different premium, or whomever else is on the plan. Whenever it showed a local school is what it showed on the site.
Doug?
No, that's not accurate. It's the LEAs, all the employees get the same rate for the active. I think, there's a lot of good questions here and a lot of concerns, but I think if we're going to talk about estate plan. My thought would be it would be wise to have the people that actually represent those plans be here before we put stuff all over TV that's not accurate.
Okay. Other questions? Doug? Paul? Sorry.
All right, thank you. So in kind of connection to everything we've kind of talked about, I'm going to talk to you about an opportunity that you have on this 4-page PowerPoint that is on your iPads. An opportunity that you have that we're discussing for January 1st, 2023 for your retirees that are on Medicare. So again, we're looking at the entire group, county government, Board of Ed. There's about 450 some odd retirees on Medicare that today you have what's called a coordinated medical benefit. So the benefit is for those who have Medicare, enroll in this plan. They have Part A through the government. They're purchasing Part B from the government, and you receive a supplement coordinated plan from Rutherford County that coordinates with Medicare. And then in addition to that, those same individuals, or the majority of them, also receive a Part D or pharmacy plan from Rutherford County that is subsidized by the federal government. All those together is the retiree Medicare coverage that you offer today. The opportunity that you have in 2023 that we're discussing gives an opportunity for you to start to save money on those individuals without taking anything away from them. So I'll let that sit for a minute, okay? If you look at the first page here, I'm going to highlight 3 things. Medicare Advantage is something that the federal government now allows us as individual carriers, Cignas, Aetnas, United, Humanas. We create a fully insured insurance for Medicare Advantage eligible people, Medicare eligible people. It's called Part C. Part C is the result of putting Part A, Part B, and Part D all under one combined insurance policy on a fully insured basis, and it's called Medicare Advantage. We can offer that now to your retirees who are on Medicare. It will drive premiums down by more than 50%, because guess what? The government says we can manage that population better than they can, so it's in the government's best interest to give a larger subsidy to Cigna to manage that population, and subsequently we can charge much lower rates than what you're using today to fund the plans I just talked about that you have in place today. The other good news is that we now have the ability to put Medicare Advantage on a PPO network, meaning all Medicare eligibles will be able to see any doctor in the network or outside the network as long as that physician or that hospital accepts Medicare and submits a claim on their behalf. So you don't have to worry about the network. Costs are lower, no network, no PCP. Some of you are familiar with maybe Medicare Advantage HMO. That's been around for a while. The negative with HMO is that you have to have a PCP, you have to stay in a silo of providers, but this is not that. This is a PPO network, it's broad. See any provider that accepts Medicare. So then let's move to pharmacy. What about my pharmacy? What's going to change there? The answer is nothing. So because you really are on already today a Medicare Part D plan with Cigna. So our Medicare Advantage PPO plan can duplicate that pharmacy plan in its entirety, from the network to the formulary to the copays, okay? So that, I want to make sure is very clear. The other thing is it's through Cigna, so it's easier administration on the benefit staff. It's something that Rutherford County can implement and add for 2023 without going through procurement or through an RFP, because you already have a contract with Cigna, so it's just another service that we can provide and just move those employees over. One ID card. A lot of your employees right now, your retirees with Medicare, have their Part A and B card. They have the Cigna medical card. They have the Cigna Part D card. It's just one ID card. It's Part C. Remember that. A plus B plus D equals C. If you look at page 3, in addition, by going to a fully insured Medicare Advantage PPO product with Cigna, we have a vast more resources that we make available to you, both from a pre-enrollment education standpoint, so all the materials, all the meetings, all the education. I've just participated in 3 meetings last week where we are doing this for Metro Nashville Public Schools. They are implementing our Cigna Medicare Advantage PPO for their population January 1st, 2022. And our staff is out there conducting those meetings, answering those questions, and educating their retirees on what they're going to be offered. After enrollment, they start to receive welcome kits. They receive wellness reminders. They receive targeted clinical communication from their providers, because Cigna now shares data with those provider groups one-on-one to share with them what the population is looking like. What does the population need? Are they taking their medications? Has this member seen you in a while? So the very last page is what you really want to focus on, what everybody's kind of getting excited about. On this page, you can see on the far left column, it says 2021 Oap Pdp Plan Cost. That's also your 2022 plan cost, so it did not change. So today, your plan, the rates that Mercer set, that the county set for Medicare retirees is about $606 per member per month. So that's anyone who has Medicare that's on the plan, that pays for the medical coordination benefit that I mentioned, the Part D benefit that I mentioned. That's what's happening today. So that's roughly about $7,272 per member per year. And keep in mind, a member is the retiree that has Medicare and the spouse that has Medicare. That's 2 members. We've modeled 4 different scenarios across the right of the page. I will say this, all 4 scenarios meet or exceed what you have today. So 3 of them, at least, are way better than what you offer today. We're offering a PPO high option, a PPO mid option, that's the medical side. We have a pharmacy plan that is called custom, and that's the one that we've designed that is most similar or identical to what you have today and what you're offering. And actually, it's the lowest cost. You could actually improve the benefits on the pharmacy that you're offering to the Medicare retirees under a mid pharmacy option or a high pharmacy option and still keep the overall costs below what is being funded today. Across the middle of the page, you'll see the rate in comparison. So the high medical plan with the custom RX plan is about $221 per member per year, per member per month. So roughly a third of what is being funded for the Medicare retirees today. And as you go across the page, you can see the PPO high standard with a high pharmacy plan. That's going to be your highest cost option right there. But again, it's less than half of what you have today, and it's much better, a much richer benefit than what you offer today. The meetings that we've had with other clients, the retirees keep asking, they'll raise their hand, what's the catch? You're telling me that it's a lower premium. You're telling me that the network doesn't change. You're telling me that I have all the same prescription drugs, the same formulary, the same network. And the truth is, there is no catch. The reason we are able to do this is strictly because the government is going to subsidize it so heavily that we're able to control the costs by having clinical management. Yes, Eric? I was. Yes, sir.
First of all, this PPO. I'm sorry, I have such a loud voice I forget to use the mic. Is that better? Oh, that is better. So this PPO, is it designed specifically for the Rutherford County, or is this just the general PPO that the normal population can enroll in?
Good question, because I need to explain that.
Yeah,
This
I've got
is
a few for
considered
you.
a group medical plan offering. So we designed this for Rutherford County to offer it as a group.
Gotcha.
It is
So
nothing like
it's
what you
unique.
get on the street as an individual.
And as far as the co-payments go, the Cigna HMO is 0 and 5 for the primary and specialist, which is my favorite, by the way. What will it be for this?
Okay. Following this meeting, I believe Susan is going to email you a 17-page document. We didn't want to share it today because you'd be reading that and not listening to me. So 17-page document that gives you the exact benefit, co-pays, co-insurance deductibles for the PPO high, the PPO mid, the pharmacy high, pharmacy mid, and the custom. So you'll see what we've modeled as suggestions. But keep in mind, when you go through that and you think, we can tweak that. That's the beauty of offering the group plan. It's not off the shelf.
So it's customizable.
We can customize it.
Okay.
Yeah.
I'm going to say just one or two last things because I have another meeting I have to get to. Anyone who thinks there's a catch to it, there isn't, because this is actually my field of expertise over 25 years, dealing with the senior market as a financial planner and dealing with Medicare Advantage versus Medicare Supplement. The Cigna plan, I deal with Cigna, Humana, United Healthcare, Aetna, and Blue Cross. The Cigna plan for the general public is one of the best plans you can possibly have. It just is an individual. If this group plan exceeds the regular public plan, then it's an outstanding plan. There is no catch to it. It includes dental, vision, hearing, chiropractic. I'm assuming you have the over-the-counter benefit. They have the new FlexGuard coming out next year. I'm assuming you have that as well or something similar to it.
I might invite you up here to help me.
I'd be glad to. I'd be glad to talk about it because this being annual enrollment, I run around like a chicken with my head cut off normally this time of year, even though I'm retired. But if normally we're paying $600 a month per member, I know for a fact that these plans, they're well under that, nowhere near $600. Plus, not only duplicating the benefit, but far exceeding it by adding what they don't have, dental, vision, hearing, chiropractic, podiatry, all of that stuff. There is no reason to not vote in favor of switching over to it. The savings to the county and the improvement to the member there's no comparison.
That's fantastic. Thank you.
My personal opinion.
Thank you. And I'd be remiss if I didn't mention there is another advantage that I was saving for last, and Lisa can attest to this. By moving from a self-insured retiree Medicare plan that you're on today, if you move it to a fully insured Medicare Advantage, you literally remove it from your OPEB GASB liability. That liability goes away on these 450 people. And what's that worth, Lisa? I mean, who knows? So the bottom of the page gives you an idea of if you were to put this in exclusive, take over, replace what you have today, under the 4 scenarios, you can see the range of savings is anywhere from $2.6 million up to $3.2 million over an annual time frame. That's the $3 million savings that Mercer was discussing, that, if you do this, you've got that in place for 2023, you can start to place those savings into your copay plan so that those copay plan rates now become a little closer and look more alike the state of Tennessee, copay plans. So you're then now, your HSA plans are pretty the same on the state versus Rutherford County, but if you start putting savings into that copay plan, you're getting them more in line.
You probably said this, but on the 606, where it says the PMPM, that is the employee's cost currently today?
No, that's a total cost. So I think today, I think the retiree is paying half of that.
Some plans, it's different.
Depending on their eligibility, they're either paying $300 or they're paying $150, right?
Okay.
Yeah, of
so
that.
that is the total cost of.
Yeah, so very good question. So then when you change the 606 to something in the 200 range, you then have a decision to make. How much of that $200 do you want the retirees to pay? Half of it or, a quarter of it? Yes.
So if we move to the state plan, is this still an option for retirees?
So if the whole county and Board of Ed moves to the state plan, no. I mean, I'm gone then.
Just when you said that if you move to a fully insured product from self-funded, which made me think if we move to fully insured on the state.
Not fully insured.
Okay.
Yeah, they don't offer this. Okay. So.
Doug.
I mean, it wouldn't preclude that. They wouldn't coordinate with it. I mean, you could still do something for post-65.
members can,
but they
any person can go out and purchase a Medicare Advantage plan on their own.
So they could do
Yeah.
a group, but yeah, I mean,
This-
that's why I keep saying, I think we need to talk to the state plan about their options.
Other questions? Mary?
I'll add one thing to
All
that.
right.
As far as anyone being able to just get this on their own, in general, that's correct, but this is specifically designed for the county. I would love to enroll in this benefit. I'm still a few years away from 65. But my options are, if anyone is familiar with Medicare Advantage, typically they're great benefits and they're certainly affordable, but this is a much richer plan here that you're talking about, I have no doubt. So I'm not an employee of the county, so it's not available to me. So on the one hand, yes, there are plans that people can enroll in, absolutely, that are good plans, but this I'm sure is much better. And even if the county didn't pick up any of the $200 a month, that's a heck of a price for it. And I'm sure the county will pick up a large portion of that.
Thank you, Eric. Mary?
Okay, I got a couple of things, and maybe just saying them out loud so we can read it back and write them down later for everybody to hear. But if our retirees, okay, if we do this Medicare Advantage, can they still be seen at our own site clinic?
Yes.
That's one that we need to address. If they move to the fully funded Medicare Advantage, would the county still be able to put in a portion, whatever percentage they decide of their share, and the employee, would that still be an option that the employees, the retirees can get?
Yes.
Saving doesn't care where they get the money.
And then another one is, this Medicare Advantage plan, you listed a whole bunch of folks, Cigna and all of them, but are we, if we put them to this, are we cutting out certain vendors or for insurance companies, for a lack of a better term, that can't offer this plan? So if we do this, offer it to our retirees, everybody's here and we all stay on the same plan. When it comes time to bid again for medical and stuff, would having our retirees on this type of plan cut out certain vendors from being able to bid because they could not offer this plan for our retirees?
I would say no, and that would depend on how you write your RFP, but this product can be written by itself. So you could piece it together with other carriers and they could have it or not have it in the future.
So it's standalone, Paul.
It could be, yeah.
It's
It could be
not
standalone.
something that says you can't have it unless you have this.
Right.
Right, okay. So kind of, and I may not get this one out right, but we can't make our retirees, if just say BOE goes to state and we stay or just for some wild chance, we can't make a special group to come and take your Medicare Advantage plan. Basically, if we swap, it's every man for themselves.
That's correct.
Okay.
Other questions? Thank you, Eric.
Thank you.
Okay. No other questions? I think the director he and his department have marching orders to get everything put together. Come back to us next month, and we'll get a report. Thank you all. Next on the agenda, we have retirement eligibility. Ms. Griffey and Mr. Elam.
Okay, so with what Paul proposed, because the plan, the Medicare Advantage plan that he's proposing that we move the post-65 retirees to, offers the pharmacy for everyone. So our current retirement language, we are starting to have a group of retirees that are not eligible for pharmacy any longer. So years of service, age, and years on the plan play into the eligibility. We have currently, right now, We have a total of 491 post-65 retirees. 474 of those have pharmacy. We have 17 that don't have pharmacy. We're going to start seeing that number climb because we're starting to fall into that 20 years of service and age 60 category now for those people as of 2010 that didn't meet the criteria at the start in 2009. So we're starting to see those 60-year-olds with 20 years of service starting to retire. So more frequently, the ones that we're approving through our office, they're not qualifying for the RX, for the pharmacy. So one other piece of this puzzle that we will have to look at is possibly revisiting the language, the retirement language, to include those that are currently on our current setup, on our current plan, that are not eligible for pharmacy, for them to be able to redesign the eligibility, revisit it, to make that group also eligible to fall into that category in the Medicare Advantage plan for the pharmacy. So that's going to take some looking at if we do decide to go forward with the Medicare Advantage plan.
Sonia?
If we did go to the Medicare Advantage plan, what impact would this have, or do you already know, or you may or may not know, what impact would this have on our OPEB liability, our GASB liability?
Because it's fully funded, as Paul just stated, it virtually takes away our OPEB liability if we go to the Medicare Advantage.
Like forever, or for that first year, or do we know?
But it's not self-funded anymore.
Okay, so that would...
The liability is much broader than just that piece. It's the people who are working and working towards like the pre-retirement.
Right, it won't make it all go away.
I mean, the pre-Medicare. No, it will not make it go away.
Right, because if you had somebody,
Lisa,
you know,
turn
once
your
they
mic
get
on.
30 years of service, let's say somebody retired at 55, but they're...
It's on.
You're on.
Okay, so if somebody retired at 55 before they got to 65 to the Medicare Advantage, you would still have that liability, but you wouldn't have the liability from 65 on. Okay.
Which is the largest portion right now.
Okay.
Yeah. Of retirees, I mean.
That are currently retired, but a large part of our OPEB liability is those people working.
Yes.
Future retirees.
Mary?
Okay, so are we just looking at potentially taking away the you can't have pharmacy part of this, or are we thinking about trying to do some of the year changes or age changes? What are you kind of thinking, that just strictly taking off basically giving everybody pharmacy? Or are we really thinking about doing some more cutting or changing of age or accumulated years, not necessarily all with Rutherford County, do some with Cannon County, Williamson County, if you taught there or worked there at the Highway Department, and then you come to us? Is that something that you were looking into, doing accumulated years as equal to what you have service with TCRS, or are you just strictly looking at the change of allowing everybody, if we swap to the Medicare Advantage, pick up the pharmacy part no matter, or take that part out?
Well, I guess to answer your question, anytime you change one part of it, I think you need to take a look at all of it instead of changing part of it because of the Medicare Advantage plan, and then come back 3, 4, 5 months later and then change maybe some eligibility in here. Instead of 20 years, make it 10 years. And I just think as far as the plan is concerned, is if we're going to make a partial change, we just review the entire plan and then come back with some type of a recommendation. That would be my suggestion. And that's why I've kind of put this in front of you, again, mostly for informational purposes and to take a look at it. I know, I don't know if Doug might want to address the problem that the Board of Education's having as far as hiring other outside of Rutherford County, either Doug or Andrea, I don't know.
One of the items, thanks Ed, one of the items, and also before I can do that, what Sonia was talking about there, with the state plans, there is a difference in that certified and classified rates for retirees, but not for all the active employees. I want to clarify, when I said that was inaccurate, I just want to say just for active. I don't want anybody to walk away saying that she was not correct on the retiree. Okay, but of course the majority of the people under our plan, we're talking about 482 compared to all the others that would be impacted. They would have the same rate, the active. But to your question, or to the comment was, as we were doing this study through since early last spring over at the BOE, one thing that came out with the study group was there was numerous times that we've had mid-career, like assistant principals from other districts, LEAs that are under the state plan. And when we talk about state plan covers more LEAs in this state than any other provider. And so basically most all districts to the east of us, all the way and including Knox County Schools with 7,000 employees, are under the state plans. Everything except one or two exceptions to the south of us, all the way to the Alabama line, those districts are under the state plans. The eligibility for retirement, if these mid-career employees were hired by those LEAs or a state participating in the state, or I'm sorry, a state department or higher ed participating in the state plans prior to July 1, 2015, they can go to another LEA and carry that retirement insurance eligibility with them. It's portable. So what HR has seen is we are seeing mid-career assistant principals, instructional specialists that they have been trying to recruit from these other LEAs under the state plans, which, like I said, that's the majority of the LEAs in the state with the state plans. They don't want to come here because one of the things is I would lose this benefit if I came to Rutherford County, because then I reset to 20 years before I get that plan, that benefit at retirement. So of course the discussion was, would there be a way to have a reciprocal, thank you. My wife says I sometimes make up my own language, but I agree with her. But thank you. What she said, agreement with the state plans that Rutherford County's plan would honor that. So that would remove that barrier for recruitment, because as we've talked about before, the universities are not putting out enough teachers. As the population of Tennessee is coming into these donut counties, because there's only like a dozen counties in the state of Tennessee that saw ADM growth. And that is not just because of COVID, that was before COVID. So we actually have 33 counties that shrank in population between the last 10-year census. That includes their student populations. We're exploding. We've had over 2,000 students enroll based on the 20th day of school compared to that day last year. We need teachers. We need support staff. We're not going to get them out of the universities, and if we have something that's a barrier to recruitment of quality teachers and support staff, we need to remove that, my opinion. And from what we've seen, is that REA and HR concurs. Thank you.
Okay, other comments? Seeing none, that will take us to the last item, item 11, our benefits and insurance proposed meeting days for the year 2022. I'm gonna need we're gonna need to go on the board to vote for this, to call the roll. Anybody have any objections? But we'll have to publish this. That's why we have to call the roll. Call the roll, Susan.
Rhonda Allen.
Yes.
Dr. Andrea
Well, I
Anthony.
need a motion
Oh,
first.
sorry,
I'm
yes.
sorry, yeah. Give me a motion, Lois. All right, have a motion. Anybody on second? Second, okay.
Who was second?
Ms. Allen.
Okay.
Yeah, go.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Doug Bodery. Amber Brown. Shay Crowell. Holly Deering. Brian Gaither. Mary Hickerson. Lois Miller. Jeff Phillips.
Yes.
Shantae Sherrill. And Eric.
Last thing I'd like to announce is our new safety coordinator. Dan is retiring on us, and Ms. Thompson, Susan Thompson here to my right, is going to be our new safety coordinator for Rutherford County. Congratulations. Look forward to having you in that position. Who's going to call roll for me now? One more time. All right.
Dan's got one more meeting, so.
One more meeting. All right, Dan. Well, and Dan, we'll give you best wishes, one more meeting, okay, next month. Okay, anything else to come before the board today? Seeing none, we'll stand in adjournment.